Thank you, commissioners, for joining us for this virtual meeting. Just wanted to note we appreciate the flexibility and apologize for any inconvenience for those of you who are planning on making the trip to MHCC for today's meeting. Due to an unfortunate situation as a result of the storm over the weekend and on Monday, we were not able to accommodate audio video in our large conference room. Mr. Chairman, I'm turning the meeting back to you, sir.
Thank you, David, and welcome to your inaugural interim role. So we'll do our best to help you out as you fill in for Ben.
Much appreciated.
So to kick it off, I want to welcome commissioners and members of the public. This is a virtual commission meeting. All commissioners are participating by Zoom. Given that it's a virtual meeting, additional ground rules will still apply. Someone has a very loud background. If folks might go on mute. That's better. Thank you. I'll begin the meeting with a roll call of commissioners. During the meeting, I'll ask that commissioners and presenters identify themselves before speaking so that commissioners and members of the public will know who's talking. All commissioners are unmuted and may speak. The public and most staff should self-mute and may not speak unless recognized by the chair. Due to the possibility of background noise, I ask commissioners and presenters to mute their electronic devices when not speaking. I also ask commissioners attending remotely, which is all of us, to avoid putting substantive comments in the chat, as it can be difficult for those of us in the room to see the comments. It also can be difficult for those of us like myself who are trying to do this on their cell phone. So MACC posts documents that will be acted on and discussed at least a day in advance so that members of the public will have time to download them before the meeting begins. We'll continue to provide advance notice on how to register for and dial into the meeting by posting that information on the homepage of the Commission's website and our various social media channels. I'll also just, David, if you can help me, since I'm for a computer-related saga, I don't need to tell you, I am doing this on my cell phone.
Oh my.
So when folks are raising their hand, if you see me not calling on somebody that's trying to, can you just prompt me?
Absolutely.
I may not. Okay, thanks. So I'll call the roll. Commissioner Agbabiaka. Commissioner Bandari, I can see you. Welcome. Commissioner Blake.
Here.
Welcome. Commissioner Boyle.
Here.
Welcome. Commissioner Baczynski.
Here.
Welcome. Commissioner Cheatham. Commissioner Douglas. Welcome.
Here.
I can see you on the top there. Commissioner Gilroyd. I think she's traveling. Commissioner Gilmore. Oh, Commissioner Gilmore's here. Commissioner Jensen.
I'm here.
Welcome. Commissioner Spinner.
Here.
Welcome. Commissioner Stratton Duncan. Commissioner Wang.
Here.
Welcome. And Commissioner Wood. Okay, we have a quorum. Turning to agenda item number 1. We have one item on the consent agenda, which is the minutes from the January 16th, 2025 Commission public meeting. Does any commissioner wish to remove an item from the consent agenda? Hearing none, is there any objection to adopting the item on the consent agenda? Hearing no objection, the consent agenda is adopted. I wonder, David, if your microphone is making, anybody else hearing a lot of noise?
I will go on mute during your conversations.
Okay. I don't know if anybody else is hearing it. I was just hearing a lot of background noise when you go off mute. And it disappears when you go on. Agenda item number 2 is the update of activities. Commissioners have received the written updates from our centers. And commissioners, do you have any questions on the written updates? I am not seeing any questions. Great. David, do you have any updates that are not included in the monthly updates?
Mr. Chairman, I have a few I'd like to note. Again, good afternoon, commissioners. First, I'd like to provide a bit of an update on the certificate of need and the nursing home acquisition documentation. Development activities for the nursing home acquisition forms have been completed in accordance with the new regulations effective February 17th. The 3 forms are the real property only form for real estate transactions with no operational role, the transfer of ownership form for ownership changes between 5% and under 25%, and the acquisition application for ownership changes of 25% or more. Next, I would like to note the annual report. The 2024 annual report is available on the Commission's website under the Policy and Legislative Reports page. I would like to acknowledge Courtney Carter for her efforts in developing the report. Commissioners are encouraged to read the report look at page 34 for the tribute to our soon-to-be former Executive Director, Mr. Ben Stephan. The next item I would report to you all is on the new contractor for the uncompensated care processing claims. The MHCC secured a new TPA, SCAS Management Group, based in Milwaukee, Wisconsin. They were awarded the contract, and staff has begun working with them to begin processing uncompensated care claims on April 1st. The last item I'll note is on an activity related to Senate Bill 786 and House Bill 812, which is the Health Reproductive Services and Protected Health Information Insurance Requirements Bill that passed in 2023. If you recall, the MHCC staff had granted waivers to the HIE vendors for the 2025 compliance year, but requested that vendors provide updates regarding their implementation plans at certain times of the year. That first period is March 30th. To be in compliance with COMAR 102507 and 102518, approximately 14 vendors will be submitting an updated implementation plan. The extension of the waiver for 2025 compliance requires that vendors who were not able to meet all the requirements, that's blocking text-based information related to codes and directed consent, they have to submit an update and show progress to meeting the requirements in 2025. Mr. Chairman, this concludes my addition to the update.
Thank you, David. And now I think Melanie Cavalier has a new employee.
I do. Thank you, Chair Sargent. So good afternoon, Chair Sargent and Commissioners. It's my pleasure to introduce our newest colleague in the Center for Health Information Technology and Innovative Care Delivery, Ms. Natalie West. Natalie will be working as a program manager in the Innovative Care Delivery Division, focusing on value-based care initiatives and advancing clinicians' use of health IT. Natalie has a Master's of Public Health with a concentration in social and behavioral sciences. Prior to joining MHCC, Natalie was an epidemiology research assistant at Johns Hopkins. So please join me in welcoming Natalie to MHCC.
Welcome, Natalie.
Mr. Chairman, if I could interrupt briefly, we have Commissioner Bandari with a hand raised.
Yeah, thank you for that. On the page number 5, I just have a question. If there was a Chesapeake Medical Imaging request for determination, can you please update? This says the commission issued a determination of non-coverage to Chesapeake Medical Imaging. Can you little bit put a light on that? What does that means and why it pertains to imaging facilities?
Sure, Dr. Bandari. I would invite our Center Director, Winnie Hawk, to comment here.
Yes, Dr. Bandari, good to see you today. We issue, that is required for licensing purposes. The imaging equipment is not covered by CON, so they just need a review by our commission stating that. So it's considered major medical equipment, and it's an exclusion.
That's right.
Thank you.
Mm-hmm.
So it still goes through the commission? If there's no CNO required, what is the requirement?
Yeah, there are a couple of different types of services. It's major medical equipment, which includes a lot of the imaging services like Chesapeake Medical Imaging. I believe kidney dialysis is another type of a service that we do not regulate. But for purposes of OHCQ and licensing, they need to have that determination. They need to make sure that OHCQ won't license them without a review by us, just to make sure.
Thank you.
Mm-hmm.
Thank you.
You're welcome.
With that, we can turn to agenda item number 3. which is a mandated benefit study, the elimination of step therapy of metastatic cancer side effect treatments. Insurance Article 15-1501 of the Annotated Code of Maryland requires that the MHCC annually assess the medical, social, and financial impact of proposed mandated health insurance services that failed to pass during the preceding legislative session or as requested by a legislator or legislative committee by July 1 of each year. MHCC staff received a formal letter of request from the Senate Finance Committee and House Health and Governmental Operations Committee on September 27th, 2024. MHCC staff contracted with Lewis & Ellis, an actuarial consulting firm, to evaluate the cost of eliminating step therapy for metastatic cancer side effect treatments as requested by the letter. Tracy Hughes, a principal consulting actuary with Lewis & Ellis, will present the findings of this study before asking the commission to approve the report. And for those commissioners who were on the call the other week, we did not have a quorum, but this is that report that we discussed then. Thank you, Tracy. Go ahead.
Yeah, thanks. Because we did, I did sort of go through a more detailed presentation a couple weeks ago. I've been asked to kind of keep it short this time, so I will do so. So next slide, please. I'll just mention here that we did see some limitations to this study. As was mentioned, this was requested by the commission in September. These are typically due before July. So there was definitely a constricted time frame. So we were not able to officially interview providers or survey insurers or get more detailed data from the APCD as we might normally do for these types of studies. Next slide, please. A couple of the key findings from the medical and social evaluation portions, a little bit of background. Step therapy is a cost containment tool and utilization management tool used by insurers where it requires the patient to try a lower cost therapeutically equivalent drug before accessing a more expensive treatment that may have been prescribed by their provider. Studies show that this can reduce effectiveness and produce inefficiencies when it comes to treatment and even result in lower medication adherence. While step therapy is common, it's applied to an estimated 40% of drug coverage policies. Some policies can require a certain or up to 5 steps before a certain drug is accessible. However, this study was specific to drugs to treat the side effects of the treatment of metastatic cancer, which is estimated to affect about 0.2% of the population. And I'll actually say 2 slides forward. So I will say that 0.2% of the population was the one of the driving factors between or resulting in the lower impacts that we got. If you can just move 2 slides forward. Which was a 0 to 0.03% estimated range. In order to produce this range, we went through various different assumptions that could affect the impact in pieces of utilization and unit cost relating to this mandate if it were to go into effect. And those assumptions and the sources that informed them are fully detailed in our report. But the resulting impact is here. And also the PMPM resulting impact was 1 cent to 30 cents per member per month. We do see this as sort of a bell curve estimation where the midpoint is our estimated most likely or best estimate for the impact. And that's my sort of short and sweet recap. So I will be happy to take any questions if there are any. I know we addressed some in the last call, but if there are any further.
And you know, many of the commissioners were not there at that call. So folks should feel free to ask questions if you have any folks who have questions.
Dr. Bhandari.
I have too many questions. Is it possible to let me? I read the brochure, these ones also, and I will tell you my serious concerns. I think, you know who is the sponsor for this study is?
I do not.
And you know which medications they are trying to say? Because this is absolutely I have not seen this, what they are trying to ask. I don't see much problem with the step-up therapy from the insurance coverage. And on page 7, they mentioned about iron, which is very rare, very rarely used as a side effects of chemotherapy. And they talk about Venofer, Parahim, Injectafer, Monoferic. I think it's a waste of insurance participants' money because iron is iron. It's like a salt, table salt. You can buy the cheapest brand or you can buy the most expensive brand. Iron is same. And I do this day in, day out, every day, 5-6 patients. I think if I am correct, Monoferic is $3,800. Venofer is $300, almost 12 times expensive. It's the same iron, same effect. I don't think it's a step-up therapy. I think the rationale here is baseless. I need to know which other drugs are. Actually, if you ask me, or even a reasonable oncologist, I think there is probably maybe some conflict of interest. We need to see who the sponsor is, which are the drugs. It's a very, vague study. And I can tell you with expensive irons, sometime, I'm on other societies, our oncology society called Maryland DC Society of Clinical Oncology. We had similar bill, I believe, sent to us last year, and that was sponsored by a pharmaceutical company. So I have a serious concerns about this study. That's what I will say.
Okay. I'm open to what you might suggest we can do about that. Unfortunately, we did have about a month and a half to get this done, so we didn't get a chance to interview, like I said, interview providers, get more information on drug specifics and things like that. We did get information from from a couple responding insurers, indicating that they did not apply step therapy for the drugs they felt were covered by this bill, and or where they did, in the certain cases where they didn't see much net savings from it.
I agree with insurance companies. A lot of time I don't agree with their opinion. This time I agree 100%.
Okay. So that I think that aligns with the ultimate low impact of the bill that we came up with. Would you agree with that?
So you're trying clarify, is it trying to say there should not be any, because I don't think there is any step-up therapy. I really, especially for the oncology, if it's pertain to side effects from oncology for metastatic, it does not apply. So if they say, well, first of all, there's no step-up therapy for most of the drugs. So which one they're talking about, I don't know. So if they want to go to most expensive drug, it's going to increase the cost by tremendously. And secondly, the, correct, those who give these drugs, they are going to make more money.
Okay.
And the pharma is going to make more money.
I have a question as well,
Okay.
Mr. Pazinski. Which
Go ahead, Commissioner.
drug? Thank you. Which drugs did you actually consider in the study? Was it just those like 5 iron drugs that are listed?
That's what,
Or
Ken, that's what I asked, which drugs are. I don't see anything.
okay, we couldn't follow what your questions were. So I still don't know the answer as to like which drugs did you look at? Because if it's just like 5 iron drugs, there's a lot more side effects to that, and there's a lot more drugs, So anyway, so what were the drugs?
Right. So we had to keep the study pretty broad. So we weren't able to find any research or do any research studies on specific the exhaustive list of drugs that this could go under. We did include an appendix of all the different side effects that are possible from metastatic cancer. So, there is an exhaustive list of drugs that this could cover. And we didn't really have a lot of time to go into the specifics. We did look at overall step therapy assumptions, and we looked at the assumptions that we outlined and the utilization assumptions that were, again, this affects a very small portion of the population. So unfortunately, I mean, we have a list of side effects and drugs that were provided to us, but we do not have any specific data on how often those drugs, like claims data from Maryland carriers, how often those drugs are have step therapy. Although overall, again, we asked two insurers, and their opinion or their assessment was that these drugs did not often carry step therapy. So if step therapy is indeed not happening very often, I think that aligns with the low impact that we came up with. I fully disclose that there are limitations to this study. Again, we did not have very much time. And there's not a lot of specific research available regarding metastatic cancer side effect drugs, especially because those drugs are used to treat, those conditions when they're not the side effects of metastatic cancer treatment. So this is very specific data. I can understand why you're wanting the very specific in the cases of patients with.
I mean, because you gave us a very specific number of the cost to each Marylander's insurance premium, but we don't have a specific list of drugs that you considered. So I don't know where you're getting these numbers from.
The numbers are based on the research that we, outlined and cited in the report. I can take a second to try to outline in an email some of the different cost sources that we used. One of them was, I believe, a study of the cost of treating side effects of metastatic cancer. So I'm happy to try to put together some further thoughts on that. But I'm not sure that I can do so eloquently off the top of my head.
Understood. So, Mr. Chairman, would it be appropriate for our opinion on this to be there was insufficient time because I don't feel as though this is a complete study, or I don't think this is giving a fair answer to whoever asked the question of what these costs are. And so, in my opinion is that there was insufficient time to do the appropriate study since we had late notification for this. And either we send a condition letter saying this is a greatly limited study that's does not reflect common practice patterns and is limited because of lack of provider input, lack of specific drugs analyzed, a couple of the other limitations, or say we don't accept this and we need more time to provide a appropriate study.
So David, feel free to weigh in. My inclination is
I will add on one more thing. Common side effects. It's mind-boggling. It's a secondary cancer. It's such an uncommon side effect, less than 0.1%. Even that's a bigger number. High blood pressure. I'm looking at the information. Bone loss. These are not common. These are very, very rare side effects. Less than 1%, less than 0.5%. I think there is a lot of information is missing, and we need more time, as Commissioner Brzezinski said, more information and more time.
So, Mr. Chairman, would the commission be would the commission be okay if staff were to if we follow the suggestions that have been discussed from Commissioner Brzezinski and Commissioner Bandari, and we go back and we look at expanding the study limitation section in the report, talk about some of the concerns that were raised, and make it clear that while this is some evidence that more time would be needed to conduct a more in-depth study on this subject matter and see what the legislature decides we should do as next steps. Would that be appropriate?
So I guess any commissioners can weigh in. It makes sense to me. I do think we probably need to let the legislature see what we have because they're in the middle of session. I agree that calling out the limitations is very appropriate. I think that makes sense. Yeah. Are there any commissioners who would be opposed to the staff putting such a cover letter together to go with the study? Okay.
I would agree with that, and I would advocate for, pretty thorough and explicit, discussion of all the limitations. Tracy mentioned them in brief as he was trying to give us a brief report. But really, looking at this, I think there's some profound limitations, that we
And-
discussed.
And if the commission finds it helpful, we could, as we draft this letter, we could share a version with at least the two physician commissioners who have spoke up at this point for input, if that would work, Mr. Chairman.
Sure, I will happy to do that. And Tracy, if you can find out who is the sponsor, that will be very helpful.
Good. I think that's a very practical way to approach. So I suppose what we could do, why don't we say we'll have a motion to approve the submission of the study with the cover letter outlining the limitations of the study due to its time, the amount of time for the debt.
First.
Commissioner Bandari has moved. Can I get a second?
I'll second it.
Commissioner Brzezinski, a second. Is there any? Yeah, I know. I'm getting old. I'm getting old, man. Is there any discussion? Additional questions or discussion? If not, I'll call the question. All in favor? Say aye.
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 Are there any opposed? Great. Thank you all. Thank you for the discussion. I think that's a good outcome.
I'm happy to follow up. I suppose my best contact would be to send to David and Jason, who I've also worked with at the commission, a little of, more thoughts that put together a more comprehensive response to the questions today.
Commissioner Sargent, yeah, we appreciate that, Tracy, and we'll follow up with you offline.
Okay, great. Thank you so much.
Thank you, Tracy. Appreciate it.
Thank you, Tracy.
All right.
Thank you, everyone. On to agenda item number 4, which is a legislative overview. Tracy DeShields, the Director of Policy Development and External Affairs, will give us an update and overview of the session, our process with regard to bill reviews and positions, and any upcoming bill hearings in the next week. Tracy, you have the floor.
Thank you. Thank you. Good afternoon, commissioners. I hope everybody's having a good day. Today, as mentioned, I am going to just provide a brief update on the legislative session and where things stand to date. Next slide, please. Just a few quick stats. Tomorrow, actually Friday, February 21st, is the 45th day of the legislative session. Everyone looks forward to that because then things start to move quicker. Bills start to cross over. You start to see voting on bills and what's passing, what might not pass, that sort of thing. March 3rd is the day that bills can be introduced without suspension of the rules. And that's just where you have to then go and ask for suspension of the rules to introduce a bill. It goes to the Rules Committee, and then you have to try to get it pulled out. March 17th is the crossover date. So that's where bills that have been introduced in the Senate and or the House, they have to cross over to the opposite houses. So if it's in the House, it has to be in the Senate. If it's in the Senate, it has to go over to the House by that date. After that date, bills go to the Rules Committee, and then it's a whole process to try to get the bill moved out and assigned to a committee. To date, there are about 1,300 bills that have been introduced in the Senate and about 17 in the House. We are tracking about 203 bills overall. Not that we're taking positions on 203 bills. Next slide, please.
Hey, Tracy, are those mostly crossover? Are there a lot of crossovers, like duplicate filings, or are those
well, actually,
three unique bills?
Oh, no, not there. A lot of times they try to have as many crossovers as possible. This year, I think there are fewer crossovers, actually, which is a little bit interesting, but I think there's fewer crossovers this session than in the past. And I think that might just be because of some of the things that the legislature's been dealing with. And so far, I think there's a lot of work that the committees still have to do. So a lot of bills have not moved thus far, but I'm thinking after tomorrow, they're going to have to pick up the pace quite a bit. So next week, and we've talked about a couple of these bills before. Next week, we have February 26th, Wednesday. There are 3 bills up that we are weighing in on. Senate Bill 902, the cross file for that was House Bill 11, and the bill hearing for House Bill 11 happened January 30th. This bill essentially would look at, it eliminates the termination date of June 30th, 2025 for certain providers who are non-participating providers to be included in where consumers can go to that provider and be reimbursed for those services, or be paid for those. The provider can be paid for the services at the equal rate. So, but this particular bill, there was one that was more generalized, like all providers, all physicians, and non-physician providers. This bill, in particular, focuses on behavioral health providers, physician providers, and non-physician providers. So those that are licensed that provide mental health and or substance use treatment. So we did, Ben testified on the House side in January on this bill in support of it. Since we did we did a study on this, and it was more general, wasn't just specific to behavioral health and substance use providers, but this bill is sort of targeted to them. And then what we've decided that the bill hearing is Wednesday coming up this week. We'll provide the same position statement, but written only. The next bill is House Bill 735. This is a reintroduction of a bill from last year that came in, House Bill 804. And this is where we had a legislator who would like to remove psychiatric health facilities and psychiatric mental health services from the CON process altogether. We opposed the bill last year, and we are proposing to oppose it again this year, and also to provide in-person testimony on the bill. If you recall, I don't know if you do from last year, the bill came in because the legislator who introduced the bill really confused certificate of need with something that the Department of Human Services does when they are looking for providers for specific services. And they issue something called a certificate of sufficiency, which it was not a certificate of need. And so not exactly sure why it was reintroduced this session, but it has been. And again, we're taking the position to oppose it. And I didn't know if anybody had any comments or about that or not. It's pretty straightforward. And then Senate Bill 691, in our legislative policy meeting, we had talked about another bill, House Bill 333, cybersecurity healthcare ecosystem. They're not cross files, but they're essentially the same bill. House Bill 333 was originally would have been heard earlier this month. However, that hearing date for that bill has been moved to March 7th. And so the Senate bill is going to be heard first. So we are looking to provide a letter of information, just sort of explaining what we do and what we require with regard to EHNs, electronic health networks, clearinghouses, and electronic medical records vendors and providers, what they're required to do with regard to cybersecurity and how they're supposed to maintain certain things and audit. This bill would require us to go over and above, I think, some of the federal requirements that are in place. It would require us to institute audits. We do have concerns about the bill, in particular, certainly the cost and basically how to sort of go above and beyond sort of what providers are already currently doing. So we're in conversations with the sponsors of both of these bills, or at least with the senator who's taking the lead on this issue. And so hopefully we will let you know next. We'll let you know via email if we nail down if I don't know if we talk to her. She's interested in amendments. We're not exactly sure how what they would look like, but we're open to having the conversation, and we can certainly follow up with you to let you know what transpired. But we are submitting the letter of information to them. Next slide, please. And then the week after, there are a couple other bills that are coming up. In particular, Tuesday, March 4th, there's a bill, Senate Bill 741, forensic mental health treatment. The focus of the bill is on providing, having availability for individuals who have been court ordered for either mental health treatment or mental health evaluation through to the Department of Health and to the Department of Health. But also in that bill, there is language that would require a psych hospital or any hospital with psych beds to file for CON in order to reduce the number of psych beds that they have. So if they want to reduce psych beds by 5 or more beds, they have to submit a full CON application to MHCC. Now, that sort of goes against the grain of what our process is currently with regard to bed capacity and reduction. So we're in talks with the sponsor, who's Senator Lamb, and we talked to him. So we're sort of proposing some language that would keep MHCC, would keep our authority over the bed capacity and the reduction of bed capacity, but then aligns it with the process that we have in place for providers to do that. I don't know. And then House Bill 333, which is going to be heard on Friday, March 7th, is the same as Senate Bill 691. And again, we're submitting the same letter of information on that one as well, talking about basically what we currently do, what is going on in the field now, and the costs of us sort of doing more, and the expertise that we would need on staff to fulfill some of the requirements in the bill. And then lastly, we don't have a hearing date for this. House Bill 1515 is the bill that MHCC has requested. It's certificate of need, and it relates to intermediate healthcare facilities 3.7. These are the ASAM substance use treatment facilities, inpatient. And we do have controls over those. And so what this bill would do would give us back the authority to be able to control bed capacity in these facilities. Right now, a provider can come in for CON, request that they say that they're going to open up a 25-bed facility. And once the CON is approved, can come back to us within a very short period of time and let us know that they want to double or triple bed capacity in that facility. And so, And right now, all they have to do is provide us with notice. And so we have seen some abuse of this. So we've talked to some of the stakeholders, and we were able to get Chair Payne-Melnick and Vice Chair Collison. We talked to them, as well as Chair Beidel in Senate Finance, about this issue. Delegate Collison has agreed to sponsor the bill on MHCC's behalf. We don't have a hearing date yet, but we just wanted to make you aware of the bill. It actually was just introduced this past Monday, believe it or not, and we got the text on Tuesday of this week. So next slide, please.
Can you say again what that bill would do with respect to intermediate healthcare facilities?
Yeah, so it would require a facility to come in and provide, essentially submit information like they would as though they were applying for a CON, except we're reviewing it within 45 days, and they would be requesting an exemption from CON. And we get the information, we would review it, make sure it meets or it falls within the health planning requirements. It's in the public interest. And I think there's one other thing that we, in our review, that we look at it, and the commission would then sort of like approve or disapprove it, or there could be conditions perhaps placed on a provider with regard to an increase or reduction in bed capacity for that facility. So it just brings it back under the bed capacity, gives us the authority to approve or deny such a request. But they're really sort of submitting the application letter of intent, and that they are requesting an exemption, and we would do the review. So it's more of we thought this was a good balance from being like, we don't do anything and trying to sort of claw back our authority, but this also gives us authority, but it also gives the providers sort of like a quicker turnaround response, gives them a quicker decision on whether or not they would meet the requirements for an exemption, and it would be approved to increase or decrease.
I'm sure everybody else knows this, but what are intermediate care facilities?
Okay, so there are different levels. So there's a 3.5 level, and then there's a 3.7. And
these are all mental health.
Yes, no, substance use, actually. There's substance use treatment centers.
Yeah.
Yes. And so it's where an individual would come in, they have more intensive inpatient treatment. It's inpatient. It's hard to sort of explain it, but it's kind of considered outpatient, inpatient, but it's inpatient treatment. And the reimbursement rate is, I think, higher than if you were 3.5. And I think you have a longer range of stay in those facilities.
And more severe levels need a CON?
Yes. Yeah, because I think they're considered inpatient, like an inpatient hospital. I don't know what the history is, but one of the things that I think became evident in the past couple of years is that you approve a CON, right, for them, they get it, and all they have to do is provide notice for a bed capacity. But because people are coming in and requesting bed capacity that is double or triple, like if you come in and want 25 beds, right, and then you're coming back and saying, we're going to add another 75. I mean, it begs the question, what's the need and the demand? And we have to think about how treatment is actually delivered. Most of it is outpatient.
Okay, thank you.
Hi, this is Commissioner Agbabiaka. I just wanted to provide clarification between like 3.5 and 3.7. So 3.5 is almost like a residential treatment facility. It's like a 28-day program where patients aren't receiving medical care, but they're receiving more like therapy, group therapy, counseling, peer support, and that sort of thing. Whereas 3.7 is like it's like a
Yes.
medical unit where
Thank
they're
you. Thank
going
you.
through
That's what I
like
meant.
medical withdrawal for like alcohol, benzos, or opiate use
Yes.
disorder.
Yeah.
So it's a much higher level of care, whereas 3.5 is these patients have a little bit more freedom, but they have groups. They can still get their medications dispensed, but there's not a lot of medical care or supervision for them. It's more about counseling and groups and kind of like that sort of thing with versus the medical. They can see a provider, but it's not a requirement for them to see a provider. And then 3.1 would be even a lower level of care where they're like living in a like almost like a sober living facility where they can go in and out of the facility and have a little bit more freedom.
Thank you, Commissioner. That's very helpful. Thank you.
You're welcome.
Thank you. Very much. Thank you.
Welcome.
Any additional questions on that? So anyway, we don't have a hearing date, but these will be bills that we will probably you'll see again next week. In particular, Senate Bill 741 and House Bill 1515. Next slide, please. And then I just wanted to go over quickly, like the bill hearings to date, where we have weighed in on legislation. Just yesterday, actually, David testified on House Bill 1104, which deals with the AHEAD model implementation. This has to do with, and I might need an assist, David, to explain the AHEAD model just briefly. But this is a new payment model for hospitals with regard to, and then I think there's also some primary care requirements. But essentially, the bill focuses on a population health improvement fund. And then within that, we wanted to clarify authorities that electronic healthcare transactions, like through electronic health networks, electronic medical record providers, certain information that might be necessary for the AHEAD model, that they, under the law, can provide that information for that particular purpose. So it's just really clarifying language. It's non-controversial, and it was pretty, well, it was only two witnesses, or basically two witnesses for this particular bill. So I think we're probably pretty good there as well. House Bill 11, Senate Bill 902, I already mentioned, that has to do with non-participating providers, reimbursement, and additional coverage. So House Bill 11 has already had a bill hearing. That was January 30th, and Senate Bill 902 is coming up this week on Tuesday, February 26th. And then Senate Bill 374, House Bill 459. The Senate bill's already been heard. I think it was heard the week before last. The House bill is coming up. I think it was this week. And so this essentially would require certain cancer screenings for professional firefighters. And we had been asked by Chair Beidel if we could do a study or provide some information on cancer screenings and what's covered and not covered under the professional firefighters. And so we did provide that information, and the letter of information just repeats the information that we forwarded to her at this time, which is basically most of the screenings are covered, and for firefighters that they would get. I think that was probably pretty clear. And then Senate Bill 393, House Bill 529, again, they've already had their bill hearings. And this was, we did just a general support. And that's because I think we did a study on generic drugs and biosimilars. So it was just imparting that particular information. And again, it was just written only, wasn't in person, just provided position of support. Senate Bill 60 and House Bill 666, which quite frankly, in all the time that I have been dealing with legislation, I have rarely, for at least in the health arena, had a bill that was 666. So it was noted at one of our meetings that that's just like not the best number for a bill. But anyway, this one is dealing with the coverage for calcium score testing. And again, we provided a letter of information because we did do the study on coverage for eliminating what would be the impact if you eliminated the cost co-payment for coverage for calcium score testing. And then the last bill that was heard deals with telehealth, Preserve Telehealth Access Act of 2025. This one simply would remove the sunset for telehealth for parity payment with regard to video call versus an audio only call, that they would be reimbursed at the same rate. So as you know, we again did another report, submitted that to the legislature. This bill, in addition to lifting that sunset provision, would also require MHCC to do a study every 4 years on innovation in this area and what's going on with it. The House bill was I think it was heard this week, and in that one they want a study every 2 years. So we'll see how that sort of fleshes out between the Senate bill and the House bill, and don't have any insight as to why the difference in the time period for the study. Next slide, please. And then coming up, we will have our budget hearing. The first one, the Senate moves the budget this year. And the first one for us is Thursday, February 27th. And then the House budget hearing is Monday, March 3rd. So we'll provide you with some additional information. We're just waiting to get our budget information or budget analysis from the Department of Legislative Services on our budget.
And Commissioner Sargent, we have a question from Commissioner Boyle.
Oh, go right ahead, Commissioner Boyle. Thank you.
Thank you. Thank you, Tracy.
You're welcome.
Are we, will it be on the budget hearings? Are we having any discussions about the funding, the state funding for the Maryland Patient Safety Center?
Oh, yes. So when this first originally came up, the commission did provide a letter of support. And I'm glad that you brought that up, because that actually skipped my mind on that. But I do know that during our budget, and I had not talked to David or Ben about doing this. I was just waiting for it to get closer. That the commission can weigh in on having that funding restored in the budget. It doesn't go in we're just a pass through, but there is a fund for it. And so that money, $1 million, could be restored, or maybe a little less than $1 million, whatever the legislature ultimately decides on that. We could weigh in on that issue, could do a letter or something, and certainly could mention it during our budget hearing. People, the public, are allowed to weigh in during our budget hearings. And so I suspect that representatives of the Patient Safety Center will make a comment during our budget hearing with regard when the public's allowed to comment. They'll make comments about the funding, what it's used for, and why it's needed during our budget hearing. And I would suspect it would be on both days that they would do that.
Okay, but so we did a letter of support for it.
Yes.
Is there more that we can do?
We could, well, you mean like
In supporting it?
lobby for it and supporting it?
Exactly.
I mean, I think we could make a comment about it during the budget. Excuse me, I'm rubbing my we could make a general statement about it before our budget committees during our budget hearing. We could do that. And certainly I don't want to use the word lobby, but we certainly can raise it. It's been raised and we've provided information and clarification about the funding. Because I think there is some confusion about it. So hopefully that gets cleared up. I do know that representatives of the Patient Safety Center have reached out to the chairs of both the budget committees. So, you know, there is work being done behind the scenes to sort of bolster.
Yeah, I just like to see the commission, you know, doing everything it can do.
So would you want would you want the commission to do something in writing? And then also,
Tracy,
you know, mentioning it during the budget.
can you hear me?
hearings.
This is Teresa.
Can you hear me, Trev? Yeah, go
Yeah.
ahead, Trev.
This is the topic of the next agenda item. We're going
Right.
to talk about what can we do to help support the Patient Safety Center. So we can talk a little bit more about it then, if you'd like.
Okay.
Yeah.
That works. Anything else, Tracy?
Next slide. No, I think that's it for that. And then I just wanted to remind you that we do have about 4 additional legislative policy meeting calls. One next week, which would be next Wednesday, the 26th. And then the following week, March 5th, March 12th, and March 19th. We do them only as needed. So I do see us wanting to have the meeting next Wednesday, February 26th. So if you, hopefully I have the right date. But anyway, if I don't, my apologies.
Thursday at 8 o'clock in the morning, right?
That's right. And I think I put Wednesdays down for some reason, but I apologize.
I think that's the 27th, but that's all right. We get the idea.
Yeah. Thank you. And that would conclude my presentation for today. And sorry, I tried to come up with a thought for the day and a dad joke, but I just couldn't do it. Next time.
Maybe next time. So thank you. Are there any commissioners that have any questions for Tracy before we move on to the next agenda item? Great, thank you, Tracy.
Thank you.
With that, we'll go to agenda item number 5, which is the Patient Safety Center. Included in your packet this month is an interim report from the Maryland Patient Safety Center. As a reminder, Maryland state law authorizes this commission to designate an organization to serve as the Patient Safety Center for our state. The MPSC develops, coordinates, and implements patient safety initiatives across the state. The current designation ends December 31, 2025. As part of the designation process, the MPSC is required to update the commission every 6 months on their activities and accomplishments to ensure compliance with our designation agreement. The interim report is included in your meeting materials. Teresa Lee, Director for the Center for Quality Measurement and Reporting, will update us on issues related to the designation process. Ms. Stephanie Pedito, I hope I pronounced that correctly, President and CEO of the Maryland Patient Safety Center, is here today to respond to any questions you may have about the report. Ms. Pedito also will update us on the recently launched Workplace Violence Prevention Awareness Campaign. Teresa and Stephanie, please proceed.
Thank you, Mr. Chairman, and good afternoon, commissioners. As Chairman Sargent stated, your meeting materials included a copy of the interim report from the Maryland Patient Safety Center. Normally, we present on their annual report and then we get an interim throughout the process. But we thought it was important to come before you today because of these more recent developments regarding the funding for the Patient Safety Center. And before I turn this over to Stephanie, I just want to remind the commission that we do designate the commission for a 5-year period, and that designation ends at the end of this year. But since 2022, they've received $1 million in funding through a non-lapsing fund that was provided through the General Assembly. So that's a bit of the conversation we were just talking about. It appears that that funding is in jeopardy. So we wanted to talk a little bit about what could possibly be done to support the Maryland Patient Safety Center. We also thought that trying to issue a request for expressions of interest, which is what we do to see if any other entity is interested in the designation. We do this every 5 years. Instead of doing that now, we were thinking it might be a good idea to provide an extension, a 1-year extension of this designation, so we can kind of take that off the table to give time for the resolution of what the funding will be, because it will be pretty difficult to see if anyone's interested, but you may not have any funding. So we'd like to consider that. And we've been working with the Maryland Patient Safety Center, the board. Commissioner Boyle sits on the board. And I don't know if you have anything you want to add before I turn this over to Stephanie Petitto to talk a little bit more about some of the ideas they have and maybe requests for support.
No, thank you, Teresa. Yeah. I mean, I've already brought up the topic that I'd like to explore what we can do to support the funding. And I think with Stephanie's discussion, it will kind of underline more how important this funding is to, a very critical center in our state. And who else is doing what this center is doing? And then thoroughly support the extension. I think that's going to be critical to be looking at. So look forward to seeing what Stephanie, has to say. But I've been very impressed with the work and the impact the center is making.
Stephanie, do you want to begin your discussion?
Sure, thank you. Thank you, Teresa. Thank you, Commissioner Boyle, and thank you all commissioners for having me here again. And so, as Teresa and Commissioner Boyle just said, I'd like to share with you a couple of things that we're doing. I'd like to answer any questions you might have on the report that we submitted. I won't go through that in detail. But I would like afterwards also to talk with you briefly about the healthcare workplace violence campaign that we're coordinating across the state. So starting with what we're doing, in addition to what you see in the written report, we are working very hard to build capacity across the state of Maryland to do the work of patient safety. The patient safety doesn't stop, with new technologies, with new care delivery, with new everything. There are new patient safety risks all the time. So to stop funding or to potentially suggest that this isn't needed is it's a grave mistake. And I'd like to give you one example just to have this hit home. So there's hospitals, long-term care facilities, others, report into the Office of Healthcare Quality various things. And the Office of Healthcare Quality certainly takes that information, but the Office of Healthcare Quality doesn't have, an improvement arm. And so one of the things I've been working with the Deputy Secretary of the Department of Health, Nilesh Kalyanaraman, on is if we could get data from the Office of Healthcare Quality, we would have a lens into something that no single hospital, nursing home, health system, urgent care center has, and we could identify statewide improvements. A very recent example of this is that apparently reports of portable oxygen tanks depleting and people running out of oxygen in different healthcare settings is occurring. And we became aware of it through some of our member organizations, and we held what we call a safe table. We got everyone together and said, we are hearing that this is happening. And it's insufficient to say, oh, we just need to train people more. We just need to have better policies and procedures. That's necessary, but not sufficient. People are, quite frankly, dying when these portable oxygen tanks run out. So this could be someone in an inpatient facility that needs to go down and get their MRI. This could be someone in a nursing home, on oxygen that needs to leave the facility to get to a doctor's appointment or something else. And so this affects different settings of care, not just hospitals. So we gathered a group together and said, what's really truly at the root of this? It cannot just be that we're not training our healthcare transporters well enough. And so what we came to is there are actually issues. Not all portable oxygen tanks have alarms. There are a couple of portable oxygen tank manufacturers that do put on alarms, but they're not audible in a healthcare delivery setting. They're not recognizable in a high stress environment. So that's one. Some of the portable oxygen tanks still have analog basically readers on them. So it's very difficult to see, how much oxygen is left and to calculate. So if you're leaving from and needing to be hooked up to portable oxygen, someone has to calculate, well, you're getting this flow rate and you're going to be gone for 30 minutes. So this is how much oxygen you need left in your portable tank. Many of them don't have that. And so either there's a manual calculation or there's, a best guess. And so what we're going to do with that is now that we said, wait a minute, there's a more fundamental issue and the ecosystem for patient safety is much greater than just the people trying really hard to work in that ecosystem. Just like in aviation, the ecosystem includes Boeing, the manufacturer, the subcontractors to Boeing. And we're saying, let us work with the device manufacturers to say, here are known safety issues with the device. Could we work together in a highly collaborative manner to address the true root causes of this? Instead of just blaming humans not hearing the alarm, let's address some of the issues. I just gave you the portable oxygen tank issue. This could be almost anything in healthcare. And that is, let's broaden the ecosystem. Let's work with the device manufacturers to say, wouldn't it be better than blaming individuals and adding resources, saying more nurses need to do more double checks, that we actually work with the manufacturers to fix the devices, the spaces, and that kind of thing. Right now, that information sits in the Office of Healthcare Quality, who doesn't have an improvement arm. We could do amazing work by having that information and being able to get it at true root causes and doing what no one healthcare organization in the state can do. And there's no one else to do it, honestly, but us. So if not us and we lose our funding, there's no one to do this. So again, I'm working with the Department of Health to put in some data sharing agreements so that we can do this really important work, but it's also going to depend on funding. So I'll leave it with that example, and I'll take questions before I talk about the healthcare workplace violence campaign.
Any commissioners have questions?
So do you know why the manufacturers are not as innovative as you mentioned?
Could you repeat that? I'm sorry.
I said you gave a great advice. Why the manufacturer of these oxygen tanks are not as innovative as you are? There must be some good reasons. I have oxygen tanks in my office. I agree with you. There must be some good reason why they don't want to change it.
I don't have a good answer to that. That's one of the things that we need to address. I think really engaging device manufacturers in the conversation. We keep hearing that, well, adding a digital readout on the portable oxygen tank is much more expensive. Okay, it's a patient safety issue. So we do have to be cost conscious, obviously, but engaging the manufacturers, and again, this is just one very, very small example. There are so many of these, but I don't think there's been a concerted effort to include them in the ecosystem And the example is, when the Alaska Airlines flight crashed, the first question wasn't, did the flight attendant lock the door well enough? It was, what happened at Boeing that door was a problem? And so that's kind of what we want to create in the state of Maryland. And we think we could be a national model for a highly collaborative working with manufacturers to say there are known safety features. Across the state, we should not be buying oxygen tanks that don't have known safety features. And again, only as one example.
Thank you.
I'm seeing no other questions, Commissioner Sargent.
Thank you.
So we respectfully request your support, and offering your written and oral support in your budget hearing would be terrific. We're we're a pass through, and we're the only general funds that the Maryland Health, to my knowledge, that the Maryland Healthcare Commission has. So that puts us a little bit at risk. So we appreciate any support that the Maryland Healthcare Commission and commissioners would give us for future funding.
I think that would be so important, and would love to hear some follow-up about that. Thank you.
So my thought, any other commissioners go in? I certainly don't see a reason why we would not put in a word just for the good work of the safety center. I know it can be a little tricky in the budget. Money.
And if I could ask for clarification, just to make sure, it doesn't sound like there's any opposition to extending the designation for 1 year in light of these recent developments.
Obviously in favor.
Is that something that needs a vote by the commission, or is it just?
I talked with the assistant AGs, and I think we don't need it, but if we do, we can come back next month. I don't think we need it.
Perhaps we can ask Caitlin or Alexa to weigh in here, Commissioner Sargent.
Okay.
Yeah, I think our opinion is that it's up to the staff's discretion if they wanted to expand it. The statute does not have a limit on the years of designation. I think the staff just chose that. I think Teresa just wanted to make sure that the commissioners were aware of it and that this was their wish.
So we would come back in the following month and make a recommendation and a rationale for why we'd like to extend the designation for an additional 12 months.
Well, David, I don't think it's necessary. From what I'm hearing from Caitlin is that we already have that discretion to be able to do it.
Okay. I'm not hearing a groundswell to pull that discretion away from you.
Can't we just agree to it? Can't we just have a vote on it now, or do we need a vote?
Sounds like we don't need one.
Well,
Okay.
Commissioner Bazinski here. So if they're looking at removing the funding for the next budget year, and we're asking them to continue it, but we don't, the budget year goes from what, July to July, July to June?
That's
The
correct.
state's budget year, yes.
The state's budget year. And this center is currently authorized to be the patient safety center
Through December of this year.
through December of this year. And would there be a problem asking for another full year of funding when we don't have a center designated for the last half of the state's budget year?
Well, we're not asking for funding at all. At this point,
But
the
we
designation,
want to, well,
Sorry?
if there's no,
the designation, if I could say this, the funding is a big chunk of the Maryland Patient Safety Center's budget. But it's not the only funding source for them. So this just simply kind of extends the issue, even though after June 30th of this year, we can no longer, there will no longer be funds to send to the Patient Safety Center.
So
That makes sense.
what you're doing is you're extending the status quo until after the session, at which point we would have to address things in light of how the session comes out. Is how I read it.
Yes.
I think that makes sense. And the commission then can look at the picture after the session and the funding and the designation and match it all up with what's available after this session is done.
Right. But the staff doesn't have to work right now toward putting together a request for expressions of interest and going through all that with everything up in the air anyway. Does that make sense?
It makes sense to me. Any other commissioners with questions, you're welcome to ask them though.
That answers my questions. Thank you.
Now, I wanted to not lose track of the second one was about what the MACC could do to help, talk about funding. I'm not averse to us sending a letter or having Tracy go to Annapolis with a signboard that says support the Patient Safety Center on the front and back of it or something like that. Unless any of the commissioners are opposed, perhaps David would leave it to the discretion of the staff of how much is effective, right? Do it, or you can underdo it. How much would be effective?
I think that seems appropriate, Mr. Chairman.
David, how much is the funding for this program?
Stephanie, it's closer to 2 million, isn't it?
No, it's 1 million per year.
No. I know the funding allocation is, but there's some other funds in the budget.
Oh, how much is our total budget?
Yes. Yeah.
1.8 million.
Yeah.
Thank you.
Sorry, I misunderstood. So thank you. I appreciate the support that the commission and the staff are expressing. I think we have such good work to do for the citizens of the state. So I look forward to hopefully a very good outcome. I just wanted to take a quick minute to give you an update on the Healthcare Workplace Violence campaign. So for those of you who are unaware, healthcare workplace violence is a terrible problem. 3/4 of all of the workplace violence events that are reported to the federal government, 3/4 of them are healthcare related. And healthcare workers are 5 times more likely to experience healthcare workplace violence than employees in all other industries. And so the Maryland legislature recognized this. And in 2022, Senate Bill 700 required the Secretary of Health to establish a public awareness campaign work group to develop a campaign. And the Healthcare Commission, via my predecessor at the Maryland Patient Safety Center, Dr. Blair Eig, stood up this work group. The work group was well represented across disciplines, and it came up with a set of recommendations for a $2 million healthcare workplace violence PR campaign. The legislature did not fund that in the first year that it was written. We strongly advocated for it last year, and it was funded out of the legislature last year at $1 million, and then further reduced by the governor's budget to $750,000. So that's not nothing, obviously. And so we developed and launched a healthcare public awareness campaign with that $750,000. And the primary goals of the campaign were to generate awareness of the issue and encourage compassion among patients and families across Maryland for healthcare workers. Obviously, we'd like to reduce the overall number of incidents, but that is a metric that's very hard to actually capture in real life. And our secondary goals were to kind of make sure that healthcare workers saw that they are receiving support in this area, and that the state of Maryland is actually working to spread awareness of the issue. And we also hope to secure more legislative support against healthcare workplace violence. So those were secondary, but still key considerations. And so we launched this campaign, and the idea behind the campaign was that we'd use real healthcare workers telling their real stories. Could I have the next slide, please? Oh, next slide, sorry. And so we launched a campaign, and the campaign was across social media sites. There were banners. If anyone was on the Baltimore Sun, the Baltimore Banner, the Washington Post, they could get an ad about healthcare workplace violence and get there's many more messages in this, but you get the idea, is that we wanted to humanize healthcare workers, and we wanted to send home the message that care flows both ways. So we've got a significant tagline about care flows both ways, and these are human beings. It was very important for us not to villainize anyone in this. It was very important for us not to scare anyone going for healthcare treatment anywhere in any setting of care. It was important for us not to uh, criticize particular populations like psychiatric patients and others. So in addition to the social media ads, the banners on news sites and that kind of thing, we have launched now billboards across the state. So we're making sure, even though there's a preponderance of hospitals in central Maryland, we're making sure this campaign reaches to the outer parts of the state as well. And so billboards, that it will run on buses, bus stops, metro stops, and other ways like that. And by all accounts, from the company that we're working with, is the campaign is doing an excellent job of spreading the campaign message. It's already delivered 4.5 million impressions to Maryland residents, with over 22,000 people viewing the website that we also created as part of this. And they're staying on the website and engaging with our website longer than the industry average. So again, 4.5 million impressions with a good average time. On the website also includes a toolkit for healthcare organizations, any healthcare organization, not just hospitals, to be able to download. So that could be like posters that they would put in their waiting rooms that have messaging like these. In addition, we kind of did the fancy word is geofencing campaign. So around the State House, again, to raise awareness among legislators also that this is an issue. And I think you might know they've got bills like the Sacred Places bill to try to address healthcare workplace violence. So it's really to raise awareness for future either legislation or funding for these types of things. And that is actually driven 31,000 impressions just in the last couple of weeks. So what we do know is that the campaign is actually being accessed in every single county in the state of Maryland. The top areas that it's being accessed so far, and it just launched in mid-January, Silver Spring, Baltimore, Hyattsville, Hagerstown, Parkville, but also all of every single county has had impressions. So by all accounts, this is successful. It's reaching people. Obviously, we would love to do more, and we'd love for this message to get out. So we greatly appreciate the opportunity to have done this, and look forward to continuing to support our healthcare workforce. So next slide, please. I think I might have had one more set of graphics just to share. So these will be what looks like on billboards and buses and metro stops. So with that, I'll end, and I thank you to the commission. I thank you for all of your support, and I'm happy to take any questions.
So thank you for this. Is a wonderful ad. Does it say if you assault a healthcare worker, what is the penalties? What is the repercussion?
No.
So if you assault a police officer, what happens?
This is something that the Maryland legislature has been less willing to address, and that is why I am told, this is when my predecessor was here, that this is why the legislature funded the PR campaign, is because they weren't going to make it a felony, but they wanted to do something.
We should ask the legislature if somebody assault them, what they will feel.
I understand.
Yeah. I think unless there is a repercussion, hopefully it is effective, because I heard a lot of complaints from healthcare workers, especially in the emergency room.
Yeah, I mean, the stories are regular. There is a Sacred Places bill, if anyone is interested in taking a look at it, that does talk about violence against healthcare workers and others in sacred places.
Thank you very much, Teresa and Stephanie.
Thank you.
Any other? If there are no additional questions on that one, we'll move on to agenda item number 6. Thank you. Agenda item 6. There we go. Agenda item number 6 is a presentation on insurance and health system market concentration study, the current status and work plan. The Hilltop Institute at the University of Maryland, Baltimore County, will conduct a study on the changing level of market concentration among health insurers and health systems operating in the state. The study will examine how market concentration and vertical integration through investment in acquisition of healthcare providers affect competition, affordability, and accessibility for purchasers, employers, consumers, and healthcare practitioners. The study will meet a House Health and Government Operations Committee request to MHCC. Dr. Morgan Henderson, Principal Investigator for the work, will provide an overview of the project and review the work plan. Dr. Henderson, please proceed.
Thank you, Commissioner Sargent. How's my audio? Can everyone hear me?
Yes.
Okay, perfect. Great. I will share my screen here. Oh, someone, no, Lavone will do it. Great. Perfect. Thank you very much for having me. As Commissioner Sargent said, this is a study aimed at both describing and characterizing the impacts of insurer and provider concentration in Maryland. Next slide, please. So today, in this brief presentation, I'll talk about the project outline, the work plan, the status, a couple of preliminary results, and then next steps. And really, the next steps is just getting into the real meat and potatoes of conducting the analysis and writing the report. Next slide, please. Next slide. Thank you. So as Commissioner Sargent indicated, this study is a response to a letter written by Delegate Josephina Pina-Melnick this past June. And in this letter, it outlines concerns about certain insurer and carrier practices. And it's a very ambitious letter. And we highlighted a certain part of the text here to understand the changing health insurance landscape in Maryland and how market concentration, as well as the acquisitions ownership of other healthcare services and businesses affect competition, affordability, and accessibility, and how these then affect consumers and healthcare practitioners. So there's a lot in this one little sentence here. And so we plan to tackle this using a kind of multi-aim study, kind of an umbrella study containing modular specific aims, which are designed to address each component of this. Next slide, please. So this is going to be one large report with 5 separate parts. And so the first part is going to be an overview of the insurance landscape in Maryland over time, and looking at Maryland compared to both neighboring states nationally, and then really zooming into granular geographies within Maryland. With the big questions being, how has insurer market concentration changed in Maryland over time? Now, this is going to involve using a bunch of different data sources, because there's a lot of different data that can be used to get at this in different ways. There's no one magic bullet data set. And so this will be kind of coordinating, doing a bit of a ballet of different data sources. And so the second part of this will be characterizing how much that carriers are paying to actual providers for certain services in Maryland, different carriers, I should say. And we're going to be using newly available price transparency data files that we work with a lot to get at that one. So that's part one. It's characterizing insurer and carrier market concentration and the prices. Part two will be characterizing and analyzing insurer provider networks in different geographies in Maryland for different specialties. We have designed a data collection template where we've circulated it to Ben and Tracy, and they're taking a look at it, and we'll be coordinating with MIA as well. With the idea being we're going to look at network density by specialty, by region, in different carriers in Maryland for their largest HMO and PPO networks. And then we're going to be consulting the literature to see if there's any evidence that we can bring to bear on Maryland about the relationship between insurer concentration and consumers' access to health services. Next slide, please. So AIM 3 is going to be another very data-driven kind of mini study. And so in this study, we're going to be looking at provider concentration in Maryland and neighboring states and nationally over time. Specifically, we aim to examine trends in market concentration of hospitals, health systems, provider groups, and ownership of physician groups, ambulatory care surgery centers, and as data allows, PBMs, specialty pharmacy managers, and health IT firms. Again, this is going to be using different data sources, for example, Medicare cost reports, AHRQ compendia, IQVIA, physician group ownership data, to try to paint a holistic picture of what's going on in Maryland, and are there any trends over time, and does Maryland seem to stand out in any way? AIM 4 is going to be a very literature heavy AIM, where we're really going to do a deep dive in the literature to essentially examine the question: what are the costs and benefits of investment and acquisitions of healthcare providers? Is there evidence that they benefit consumers through perhaps lower provider costs or more integrated care, or is there evidence that it seems to that it places maybe restricted access on consumers, or it raises costs? And so we're going to lean on the literature for that. There is a voluminous literature on this topic. We're going to endeavor to stick to the more recent studies. We're going to absolutely use our subject matter expertise about the Maryland health landscape to draw conclusions as appropriate and applicable to Maryland's unique health services landscape. Next slide, please. And finally, we will be offering a few policy options that Maryland can take to promote competition, transparency, and accountability in healthcare markets. And again, we're going to look at what other states are doing. We're going to consult the literature, look at what Maryland's already doing, of course, and so hopefully make some sensible, actionable policy option suggestions. Next slide, please. Okay, this is a lot. Umbrella report, 5 mini kind of standalone studies. Next slide, please. So what are we doing, and what's the status? So we are very, very close to securing access to 2 restricted data sets that will be used in this study, among other data sources. The APCD, first of all, and that one should be done, and then IQVIA. So IQVIA is they do many things. They're among those things is they sell access to provider level data that contains ownership, which is very important, especially for physician groups, because that data is not publicly available. And so we're going to be finalizing our procurement of that. It's very close. Designing and disseminating this carrier network template. The draft is done. We're just circulating for comment now. We'll be downloading, processing, and analyzing many different data sources, which they range from the CMS MLR files, MHBE analytic dashboard files, AHRQ ownership compendium files, the NPES NPI database and area resources file, and many different of these transparency and coverage price transparency files. So there really is a tremendous amount of publicly available data. We downloaded most of this stuff in November. It doesn't look like it's been affected by any of this, these recent kind of federal level actions where data seems to be disappearing related to certain topics. So no concerns there. This is in progress. Many of them are complete. Next slide, please. And so as soon as we get access to the restricted data sets, we'll be diving in. Again, just using them to characterize either insurer consolidation over time or provider ownership over time. Collecting literature, the relevant literature. Again, there's a lot. This is in progress. We will be doing an interim. We interim report, coordinating with MHCC, Ben and Tracy. The report outlined various kind of milestones, and many of these are done already. And so the deadline for this, for final plus a 4-page infographic, just to get the the summary highlights of what will probably be an 80 to 100-page report, and just condense it down to a nice, visually friendly, engaging infographic. September 1. And so we look forward to these next few months where we'll really just be getting into the work. And then once the report is finalized and submitted, we will be happy to present results either to the commission or wherever as the case may be. Next slide, please. So again, key dates, September 1 is the date that we're kind of working backwards from. We'll be submitting the draft with certainly sufficient time to Tracy to solicit feedback, and many of these early interim steps they're already complete. Next slide, please. So preliminary results, only a couple of graphs. Next slide, please. So this is from CMS MLR data, and this is, of course, I'm sure everyone knows this data source. It's a good data source. It's limited. It's at the state level, but it has a lot of very useful information that can be used to characterize the fully insured market segments in Maryland and other states over time. And so what we have here is 4 different graphs looking at the market share in terms of number of covered lives of the largest carrier by segment in Maryland over time, and then the average across neighboring states. So that's Pennsylvania, Delaware, DC, Virginia, West Virginia, and then nationally. And so we just wanted to see how is the insurance market evolving in Maryland compared to both neighboring states and nationally. And so we see that the top left graphic, in terms of the market share of the largest carrier, and in Maryland, it's CareFirst in every year and every market segment, probably not surprising. It's relatively high, the market share. So combining across individual, small group, and large group in Maryland, which is about 1.5 million in 2023, the latest year that results are available, data is available. It's about 60%, with between 60 and 65%, pretty steady, maybe going up a little bit, a little higher than the national, which would be bopping between 55 and 60%, and then a little bit higher again than neighboring states. So, okay, big picture, it looks like Maryland is not a huge outlier in just the fully insured insurance landscape writ large, but there is a relatively high degree of concentration. Now, moving clock.
Can I ask you a question here? Why have you chosen to only do the commercial insured segments of the market here? You don't have self-insured. Your total number of people covered is 25% of the state. So 75% of the people, almost all of whom have insurance coverage, aren't included in your market here. If you look at commercial insurance, in particular, if you add the self-insured marketplace in, CareFirst drops to somewhere in like the 20% range, because we face intense competition from national carriers far, far bigger than we are. And I think if you look in the individual market and you say, gee, CareFirst has a huge share of that, and you ignore the fact that there are major national carriers who have chosen not to be in the individual market for one reason or the other, but have networks, they have robust contracted networks across the state. They are already there, and it would cost them almost nothing. I think looking at just provider rates is not going to explain to you what's going on. So I want to make sure, I want your study to actually look at the market dynamics of why is it that CareFirst and Kaiser were the only people in the individual market, the only carriers that stayed in when ACA started. And then we lost, I don't know about Kaiser, but CareFirst lost $150 million a year for the first 3 years under ACA, almost $500 million. We stayed in that market when every commercial carrier left because we were committed to the community. Then the state, which we helped work with them on, enacted a reinsurance program to stabilize rates in the individual market. And what ho, unsurprisingly, commercial carriers started to come back in, but they've come back in with products that often underprice CareFirst products and attract the healthiest risks. And there are many folks who will pick CareFirst even though the product is more expensive because of lower claims denial rates, service that they're happy with, things that would not necessarily be provider rates. I think you need to look at all of those things to understand what's going on. I think just a comparison of, oh, look how many contracted providers there are, look how many commercial members there are, is not actually going to tell you about market concentration, or it's not going to tell you about its impacts.
No, we appreciate that. That's great feedback. We're taking notes.
But I think it's a great study. I don't want to be critical of the study. I just feel like it needs to look more broadly.
Of course, and that's one of the difficulties of this kind of study is it's difficult to include that self-insured group. Now, the CMS MLR data, it does, if a carrier, if there's a TPA that's also a carrier, they do. So we know that Cigna has 900,000 approximately lives as a TPA. So we can, there will have to be that caveat of if there's just TPAs that aren't carriers, and it seems most of them are, as far as we know. So yeah, we take that, we will work that in, and then these other, yeah, that's, we have, the next slide is actually drilling in on the individual market. So no, but we take your point, and yeah, much appreciated.
And the cross substitution, right? Like you're in the carrier market, there are big competitors that are outsized for Care First that are choosing to participate or not based on things that aren't like capability of being in the market. I think it's a little different, say large hospital systems. It'd be really hard to just hop in with a big hospital system, build them next to Hopkins and say, now we're competing. So I would just put that as a factor in your study when you're thinking about what does market concentration mean in that case? How easy is it for someone who chooses to enter if the economics are where those commercial carriers want it to be? You're seeing, for example, in the individual market right now, there are a number of new products. Elevance, also much bigger than Care First, has filed under the WellPoint name. I think Centene, which is a Medicaid carrier, has the network, has filed, maybe filed or in the process of filing. But if the federal government does not extend to the enhanced advanced premium tax credit, you may see those carriers just go away because the margin that they want to get won't be there. So I think it's an important, I won't belabor it, but I would want you to factor those considerations in there.
Yes, no, absolutely. This is a crude way of describing the market. This in no way fully characterizes the market. Completely agree. This is in the spirit of preliminary results. Again, so similar graphs, just drilling in by fully insured market segment, individual market, and then going clockwise, large group, small group. And so this is one of the kind of data analyses that we'll bring to bear. Again, trying to really describe the dynamics of what's going on in the insurer landscape over time. Next slide, please.
Excuse me 1 second.
Oh,
Morgan.
yes.
I'm not as facile in insurance issues as Chairman Sargent is, but I'm curious, in that small group market and large group market, there seemed to be a drop in the large group market in Maryland with a reciprocal increase in the small group market. Is there some correlation, like suddenly they redefined what it was, or companies all shrunk?
The definitions haven't changed.
Yeah.
Okay.
I suspect that it's got more to do with groups going in and out of the self-insured market versus their respective segment than say employers changing size or anything like that.
Well, we know that the small group market, it is shrinking a bit over time. 235,000 in 2023, just total across all carriers in that market. It's going down. It is going down a bit, and so this may reflect in some way dynamics again into who's self-insured, not self-insured. It could in part reflect a kind of a changing structure of the Maryland economy in principle. So, we will certainly pay attention to that. That is a good comment. Why the big drop? Yeah, we looked into the big drop. I don't remember what it was in the large market. That certainly is, it's large though, from 2016 to 17. And then it seems quite stable
very
there.
very sudden as well.
Yeah.
So,
I think it's probably just, there was a new carrier that entered the market then or something like that. We can, happy to follow up offline. It would be easy to check. But it will relate to in some way a new carrier coming into the market, almost certainly.
Okay. Thank you.
Yeah. Next slide, please. So zooming in on then just the individual market. And so using a different data source, just MHBE analytics data. And so this is great because it doesn't just have carrier, it has carrier and plan. plan type as well. So HMO, PPO. And so what we can do with this one is just, again, use it to drill in and really try to trace out what's happening in the individual market in Maryland over time. And so it's not a surprise to anyone. It's been going up. We're in the first 200,000 and then really edging up almost to 300,000. Care First so there's two Care First plans. There's HMO and PPO. Those are quite a big chunk, but the Care First presence has been shrinking really. And we see that gold line of United. United has been becoming more of a presence and absolutely as Chairman Sargent indicates. So this data is through October 2024, and then we will certainly refresh it. And there will probably be Elevance, they're in the market these days. So again, this will be a very interesting graphic, which kind of speaks to the competition, the competitive landscape of the individual market. And yeah, it's pretty robust. I mean, there's several different options. There's not a gigantic dominant carrier plan. And so again, this is just another kind of view using a different data source to try to characterize what's going on in the Maryland insurance marketplace, individual in this case, over time.
So is the
Next slide.
is going up because they are at cheaper rates?
Pardon me, United?
United share is going up because of the cheaper?
Yeah. I'm not sure, to be honest. We haven't looked at that yet. We will certainly try to understand why things are changing. Perhaps Chairman Sargent has a perspective on that. I don't know off the top of my head, though.
Not really. I have the joy of being a lawyer.
Yeah.
I can give my opinion. I think they want to cherry pick the healthy people. And I usually tell my patients, if you have to pay a little more for Blue Cross Blue Shield, go with that. It's less pain for me and less pain for you also.
Commissioner Bandari, we have a billboard you might be interested in. That's awesome.
And Morgan, why is the total enrollment going up? I mean, that's a really significant increase.
Yeah, probably because of the enhanced premium tax credits. These were from, so initially in the ARPA Act 2021, and then reaffirmed in the Inflation Reduction Act 2022. And so it's just, yeah, I mean, it's low-income people under 150% federal poverty limit, they can get zero premium plans because of these enhanced tax premiums. You couple that with Medicaid redeterminations, people coming off Medicaid. So I think that explains the overall rise. This is happening everywhere.
Yeah, just for the rest of the commission, they have had advanced premium tax credits since the ACA started in 2014. Yeah. They raised them during COVID. So there's a whole group of folks who can get subsidies now that we're not able to. They will expire this year unless Congress acts.
Good information. Thank you.
Exactly. Yep. Next slide, please. And so in terms of what's next, next slide, please. So finalizing and disseminating the carrier network survey, we want to leave enough time to give the carriers enough time to fill things out, provide support to them, analyze the data, get access to their various restricted data sets we need, and then really continue the data analysis. This is a big topic with many different aspects to consider, and we're really going to dig into it. And so, you know, we were kind of champing at the bit, ready to be off to the races here. And, you know, thank you very much to the commissioners for your thoughtful feedback. Very happy. If there's any questions or comments, please just follow up with myself or my colleague, Dr. Morgan Muslim, who will be co-leading the study with me. Next slide, please. Yeah, that was it. So that's all we have for today.
Thank you, Dr. Henderson. Are there any questions?
Are you both named Morgan, did you say?
Yes, sir. Yes, we are. Yeah.
That's not confusing. All right.
Small
Dr.
world.
Henderson, thank you very much.
Thank you, sir.
Thank you, Dr. Henderson. With that, we can go on to a substantive agenda item, which is a presentation on the APM report, outreach update, APM quality analysis. In alignment with chapters 298 and 297 of the 2022 laws of Maryland, Senate Bill 834 and House Bill 1148, the MHCC is tasked with reporting annually on the number and type of value-based arrangements, quality outcomes of value-based arrangements, number of complaints made regarding value-based arrangements, the cost effectiveness of value-based arrangements, and the impact of two-sided incentive arrangements on healthcare practitioners' fee schedules. This presentation is an informational-only update to the December 2024 Alternative Payment Model, APM report, and will focus only on the quality outcomes of value-based arrangements. Ms. Sarah Lindberg, Senior Data Scientist Consultant with Friedman Healthcare, will present the key findings. Sarah, you have the floor.
Thank you very much. So as stated, this is an update to the report you saw in December related to the quality performance depending on folks in the fully insured market, whether or not they are participating in alternative payment models. So the first slide here is just designed to remind us that this is a law that was passed in 2022 that helps the state of Maryland track non-fee-for-service or FFS payments and trying to categorize them based on a national framework known as the HCP-LAN categories. And it arranges these payment arrangements on a scale from category 1, which represents fee-for-service without any link to quality or value, up to that category 5, which is true population-based payments. So this gives you a chance to see over time what proportion of folks in the fully insured market are associated with these and how do they differ based on things like PMPM and quality results. So the next slide just goes over the quality results that we're focused on for this particular study. So the data management vendor is a certified HEDIS vendor, so they are able to run 7 certified measures. For prevention and screening, the measure was breast cancer screening. For diabetes, it was eye exam for patients with diabetes. When that originally went out, it was actually a composite measure, but the measure had been retired. So there were 3 components of that measure that were still being run. And this is the only one that didn't really need a clinical component to the measure to really make sense to look at through claims. For behavioral health, it was follow-up after an ED visit for mental illness, and we looked at both 7 and 30 days after that first visit. And then in terms of overuse and appropriateness of drug use, there's the risk of continued opioid use for the folks with the more than 15 or more days of prescription opioids in a 30-day period. And finally, there were 2 utilization measures, one being acute hospital utilization and the other one being ED utilization. We were able to run the measures on all the full database for 2022, but for 2023, we only had complete data for the commercially insured population. So we only have results for that subpopulation in 23 so far. The next slide just shows an overview of those results by payer type in 2022. As you can see denoted in blue, the commercially insured population did the best on all measures, which is certainly expected for many of them. And also noting that the last 3 aren't even run on the Medicaid population. That's just a commercial and Medicare population. But in general, as you'll see on a later slide, these are within expected values compared to what is submitted to MHCC for their own HEDIS plan reporting. The next slide shows us some change over time. So again, since the commercially insured population is the only one population for which we have data in 22 and 23, they're the only ones that we're able to display longitudinally. So among that population, 2 measures stayed consistent or improved, with breast cancer screening improving by 1.5 points, and the risk of continued opioid use staying pretty stable. The remainder of the measures declined slightly, and in some cases, such as the ED utilization, by quite a bit. Seeing changes to those results over time, but we don't have a measure of statistical significance. That's one thing we're exploring for future reports. It's hard to estimate the effect size for some of these measures. The next slide shows just the subset of the fully insured and what proportion of those are participating in an alternative payment model. So of the filings received for calendar year 2022, 11% of that fully insured population was participating in the APM, and that nearly doubled up to 20% in 2023. I mention that just because as we track these changes over time, it's possible that some of the differences we see in the APM population in particular may be driven by a change in population rather than any difference in the management of the plan beneficiaries. We just almost doubled the population. So on the next slide, we kind of just highlight the overall results that we found. So for 3 of the measures, the members associated with all-payer models performed more favorably. That was for breast cancer screening and both of the follow-up after a first ED visit for mental health. And overall, they showed more improvement in the measures associated with ED utilization, even if their outright results were less high quality. So we'll go through those on the next set of slides. So this first one is got 2 measures. So the first is breast cancer screening, and on that top line, you can see that the APM population improves by 2 percentage points in that measure from 22 to 23. And we don't see a change that exceeds 1% or more or less for the non-APM population. And we see that the APM population was 3.5 percentage points higher than the non-APM population in 22 for that breast cancer screening. And that lead increased by about a point in 2023. They stay about 17 points below the non-APM population across both years, with that measure staying flat for both populations. On the next slide, a similar comparison, but this time we're looking at that follow-up after a first ED visit for mental illness. So we see the results are largely unchanged for that more timely follow-up within 7 days, but the APM population shows results about 5 percentage points higher than the non-APM population. And they showed quite a significant improvement in the 30 days after follow-up, or 30 days after the visit, increasing by nearly 3 percentage points as compared to a decline of nearly 2 among the non-APM population. So their relative performance increased to almost 10 percentage points higher than the non-APM population in 2023. All right, and this should be the one of the last try number slides. But here we have that risk of continued opioid use. So we see that there was a slight improvement. Lower is better in this measure among that non-APM population, and a almost 1 percentage point improvement among the non-APM population. So they stayed pretty close to each other, but the difference narrowing a little bit. So that is kind of the overview of all of the results to augment that report that you've already seen. Oh, I'm sorry, I forgot the utilization measures we still have here. So those are in the next slide. And we see that for acute hospital utilization, not a lot of change longitudinally over time, with the non-APM being about 7 to 7.5 percentage points better, or having better utilization than the non-APM. But we see them really closing the divide on the ED utilization, that rate declining by over 6 units. Those are member years, members per 1,000 member years for the APM, and a decline of an increase in that utilization rate in the non-APM population. So that gap narrows by about 10 units, which is something special. So that was officially all our measures. So then the next slide, we just have this is what we've done is we've adjusted. Remember, I said the population almost doubled. So this is applying a age-sex adjustment to both years, so that we can at least control for anything related to those components of the quality results. And you can see if you just look at the APM population, we see improvement in all but one of the measures which does stay constant. So it does seem like there certainly is a different population in the 2023 filings than we saw in 2022. So it's good to have those factors to help account for those differences. And last but not least is we have, as I promised, some benchmarks, so you can see how on this last slide, there should be, there we go. So that's the benchmark. So it's a weighted result of the HEDIS results based on membership for the measure compared to what we're getting for this APM population. They're not perfect matches. We wouldn't expect them to be. They do come from different places. So this APM analysis is just run on APCD data. It does not have any of the clinical or chart review or other supplemental checks that the plans go through as part of their HEDIS measure calculation. So in general, those results tend to be a bit higher than we see out of an APC generally, but we just wanted to show that, nothing seems like completely out of the ballpark of what we'd expect compared to what we saw in those filings. So that's the material that we had presented or prepared for you today. Any questions that we can answer before we have you go on to your next agenda?
Thank you. Any commissioners with question?
Mr. Chairman, I'm not seeing any hands raised.
Thank you. Thank you, Sarah. I think you had the luxury of coming at the end of the day, but it was a very good presentation.
Okay, thank you.
Mr. Chairman, your approval to go on to agenda item 8?
Yes, sir.
Okay.
Would you like to share the upcoming activities for March's public meeting?
Yes, and thank you. Our meeting, Commissioners, Mr. Chairman, is on March 20th. And for that meeting, we have 3 action items related to Certificate of Ongoing Performance for PCI, one for Sinai Hospital, this next one for University of Maryland, St. Joseph Medical Center, and the third one being for Tidal Health Peninsula Regional Medical Center. We also have an action item related to regulations. This would be COMAR 1025-18. It's the Health Information Exchange Privacy and Security Regulations. The Commission may recall that we released the regulations in the fall for public comment. This was to modernize them with the 21 and 22 legislation. We've worked closely with the AAG and stakeholders, and we'll be presenting at this meeting in March the final recommendations or final proposed changes as final to COMAR 1025-18. And then lastly, we'll have an update by Tracy DeShields on the legislation overview. And with that, Mr. Chairman, I can conclude and hand it back to you.
Thank you. Any commissioners with questions on the agenda? If not, I will entertain a motion to adjourn.
I don't know. This is, hello?
Was there a question? Yes.
This is Commissioner Blake. It's not necessarily a question, but maybe something that we could discuss at the next meeting. I was just, it was brought to my attention recently, the last couple of days, about Bill HB 1081, and that's around mask wearing, and that the Maryland General Assembly will be voting on, I think later on this month. I'm not sure if this is necessarily the body to have this discussion, but it would be interesting for us to learn a little bit more about that bill and have a discussion around whether or not we should have a response to it or not.
So, David, can we ask Tracy to talk about it at our next legislative call?
Yeah, that works. And Commissioner, we'll have to go back and check the bill number because I thought I heard you say 81081. Is that correct?
It's HB 1081.
1081. Okay.
Yeah.
Sure. Tracy, can you comment?
Sure, I'll look it up and I'll send it out to everybody if that's okay, so that you at least can look at it so you know what the bill is. And yes, we can discuss it.
And just to note for the commissioners, it is the title of it is Criminal Law Mass Intimidation Prohibition Unmasked Hate Act. And Tracy, as noted, will send it around. Thank you, Commissioner Blake, for bringing that to our attention.
Yeah.
Great. Thank you, everyone. I think I heard a motion to adjourn.
Motion to adjourn.
I'll move. Thanks, everyone. Thank you for your flexibility today. Have a great day.
Thank you.